Is the next Jacob DeGrom. Jacob DeGrom's currently on my fantasy IR, so it's a great topic. And we have a great panel here with us. So let's get right to the cases. So this will be very case-based as the prior panel. So let's meet our panel. Where's Brandon? Is he out spending the money? All right, well, Brandon's supposed to be on our panel. We all just got to meet him last time and see his skills in the Family Feud. As we all know, Brandon apparently hails from New Jersey, but he's in practice in New York. And when I did an internet search, the only thing I found related to baseball with him is they quote him in this article about Pete Alonso having trouble after participating in the home run derby. So he's going to be one of our experts. Kyle apparently played collegiate hockey in 1989, 1990. This is also on the internet. So he's going to add a little bit of a tough guy approach to how we manage the next Jacob DeGrom. So Kyle, thanks for joining us. Albert Lynn at the University of Pittsburgh. We play them sometimes, and unfortunately Pitt baseball was left out of the NCAA last year. So sorry about that, Albert. Good job. Samir Nagnan, we all know him from his exploits with the women's national team. He's going to talk about Jacob DeGrom. I found these also on the internet, including this kind of awkward photo of him kissing the trophy. I'm going to leave that up there for a few minutes because it's just kind of haunting.
My wife's here. She's a little jealous.
So congratulations, Samir. None of us have any of these particular medals, et cetera. To tell us actually how we treat these patients, because in general we do our best not to operate on any of these, we are very thrilled to have Yoni Rosenblatt. And interestingly, he spent some time with the Israeli team in the Olympics this year. So I'm sure he's going to educate us quite a bit on good strategies to manage these athletes and try to keep them out of the operating room. And then finally, Robin West, Miss DC Nationals. So she's going to give us the professional approach to how we manage these real Jacob DeGrom type athletes since she deals with them on a day-to-day basis. All right, so let's talk about some cases and we'll see where this goes. Encourage audience participation, so if there's any questions, comments, trash talk, anything, feel free to come up to the mic and share with us. So these are a couple cases of mine. This is a guy I treated a couple years ago. He's 18. He's a local guy, so he's from Charlottesville. He's right dominant. This is right shoulder that's been bugging him. On and off during high school, never really did anything about it. He was recruited to play at William & Mary and was going to go there in the fall. But in the late spring, early summer, he was playing some summer ball. He was actually playing shortstop at the time. He tried to rip a throw across the infield, and at that point really felt something significant go on in his shoulder, and his shoulder's been painful ever since. He describes his pain as posterior in location, pain with late cocking primarily. He's lost velocity. He can't really throw very well. And he comes in, it's June at this point in time, and he's planning on leaving for college. I don't know that the William & Mary folks knew anything about this at this point in time, but this is when I'm seeing him in the office. So Samir, since you're sitting right next to me, how do you approach this patient? What are you thinking when this type of patient, which we see pretty commonly, comes into the office?
So this person here, on and off shoulder pain for all this time, gives me concerns that he is kind of reaching the end of his line, or something's wrong with his mechanics that he keeps having trouble over and over. So that's my first thing I'm thinking about. Secondly, he's going off to college where he's going to have a huge bump in his innings throwing and also the competition. So he's going to have to throw harder, faster, and more often. So I'm really worried about his longevity, first and foremost, is the first thing. So I'm really going to spend some time talking about his mechanics, how much he throws, and all that other stuff.
So Brandon, does the location of the pain kind of steer you in one direction or the other? Is that something that you pay close attention to?
Sometimes, depending on if it's more anterior over the biceps, that clues me into one thing. If it's mostly lateral, just generalized shoulder pain, then I don't think it adds too much to me. When these guys come in, I usually perform a cursory exam of everything else too. So just a quick minute on their hip, shoulder, and elbow motion. Because if their hip motion stinks, not necessarily even for pitchers, but even for position players, if they're like their landing leg hip motion stinks, specifically their internal rotation, it'll put a bunch more stress on their shoulder and elbow. So I just lay them down real quick, and I do part of the shoulder exam laying down, and then I'll do a quick sleeper stretch exam on them and just see what their internal rotation's like with their arm at 90 with their scapula stabilized by the bed.
All right. Kyle, anything additionally you like when you're examining these patients, kind of unique things that you use in the office?
Yeah, I think the most important thing here is just the history of it on and off during high school of a more chronic problem and then a sudden increase in his pain. So I think that loss of internal rotation abducted is kind of the biggest thing I'm looking at. I also want to, just evaluate his cuff strength and any instability. But the picture is looking more towards like an internal impingement type of thing. So.
All right. Albert, how are you going to work this up further? You going to get X-rays? You going to get MRI? You going to what's your next steps with this guy?
Well, I think a couple of things we didn't talk about here. He hasn't, not sure if he's had, PT, physical therapy, and if he has, what it's concentrated on. A couple of things here that concern me. You said he has a loss of velocity, loss of accuracy. So those type of things usually can persist sort of kind of later down sort of the kinetic stream. And so, I would do the same thing, toe to fingertips, basically make sure that all the things in the kinetic chain are kind of addressed as scapula. And then, I would, assuming all of that stuff has been done, I would start off with some, basic x-rays and then kind of go from there.
All right, so you guys keep talking about the toe to fingertips or kind of the top to bottom evaluation. Albert, give me the 3 tests that you think are most useful looking at that kind of stuff. What do you use? Because you're not going to do a toe to fingertips really in your office, right? So what are the things you really do?
One of the things I think I learned is from Buddy Savoy. You can have somebody do sort of a single leg squat, basically, and that gives you a very good sense of whether or not their core and their hips are strong. Often these high schoolers, they'll collapse right away, and you know that that's an immediate problem. And then probably after that, range of motion assessment is, for me, at the shoulder to look at GERD and things like internal impingement. And then you can do the provocative tests, O'Brien's and the other things, assuming that everything else looks pretty good.
All right, so Yoni, tell us what we really should be looking at when we're looking at these patients. Well, what do you do when you initially, because we're going to see this guy more than likely, so he hasn't had any treatment yet, more than likely we are going to get him assessed and try to rehab this for a bit.
Yeah.
So take us through kind of some of the key things you're looking at when you're initially evaluating this type of patient.
So first of all, as a PT, I loved hearing that toe to fingertip. That was really impressive to hear. I would love to see it.
It's actually toe and fingertip. That's all it is.
Just those two.
So do we have time to see what that would look like? No?
What do you mean?
I would love to see a doctor do a toe to fingertip.
Oh yeah, who do you want to do that?
Dr. Murthy. So that's great to hear. I think that you're smart. Yeah, I've learned. I think that's great. I think that's what I would do, probably a little bit more thoroughly. Like I want to see how the whole kinetic chain moves together. I love the doctor's idea of a squat, a single leg squat. I would love to see that with arms raised overhead to see how they control that, because they're going to make their living in that position. So I think that's really important. I would also pay close attention in terms of range of motion to the contralateral side, and just to see where that kind of falls, to make that a piece of the puzzle.
Yeah, and when you're looking at range of motion, is there a way that you feel like you can tell whether it's a soft tissue based problem or more of a bony problem? How do you kind of assess that, or is there a way to assess that when you're initially evaluating these people?
Yeah, I try to keep it very simple in terms of active versus passive ranges of motion, and how far apart are those two things. If they're far apart, I'm really thinking that it's a weakness position. And so I'll assess them appropriately. I would also, maybe like a pearl to add here is, what do they look like closed chain? How do they look in a high plank position? What's the scapula doing there? I think that's very important, because it forces the entire cuff to kick on to attempt to stabilize. So I think that gives you a little bit of information. So overhead squat, high plank position, supine active versus passive range of motion.
So Robin, this guy's history is one where he's got this kind of nagging stuff, but then he had this one moment where he felt something happen. Clearly the timing is going to be pressing you a little bit. It's June, he's going to college, he's a pitcher, and he feels like he can't throw. What's your approach to this from the standpoint of imaging workup? Do you try to keep him out of the scanner? Do you get the MRI to get the information? How do you kind of manage this? Because I'm sure seeing this, and these patients typically want to know what's going on.
Yeah, it's interesting. I think at the collegiate level, it's different than the professional level. The collegiate level, they're more apt and they're asking for the MRI. At the professional level, the guys don't want the MRI, because guys sort of know what it's going to look like. But with this chronicity and then this acute pain, the acute pain is more concerning to me. So I would obviously do this thorough exam, make sure that I look for any atrophy, really do a very good exam on him. But I'm leaning to getting an MRI sooner, again, because of the acute nature of it, and also he's leaving for college. So we want to have an answer soon.
Samir?
Another point to ask him is, is he thinking about redshirting? What do they want him to play? Which position they want him to play? That would play into this thing too, in terms of talking to his coaches about this.
Yeah, they don't know about this yet. And so really this is a guy who's trying to figure out what's going on with his shoulder. Would anybody discourage him from getting an MRI at this point? All right. Well, here's his x-rays. Anything you see that stands out? All right, good. Here's his MRI. So this is what we're seeing, and I'll kind of work through this clip by clip. All right, a couple representative views there. All right, so we'll go back.
I'll just mention on the X-ray though, that osteochromial
Yeah,
may
the
be significant.
I was going to ask, is it significant? What do you think about that, Kyle?
I was looking for edema on the MRI, but I didn't, I missed it.
He didn't have any, so I mean, on the axial cuts is where you're probably see
Right.
it the best, and he really didn't have much. How much do you pay attention to that in the overhead thrower?
Well, for all my patients, I think, that's an important part of the examination, actually mashing on the anterolateral acromion. And then if that appears to be symptomatic and also impingement is painful, and I see edema around the os on the MRI, then I'll consider that a symptomatic lesion.
And then what are you going to do with that?
In this patient population, I would try a period of rest for sure and conservative treatment. But ultimately, I've had great success with excision of osteochromialis, even in heavy weightlifters and athletes.
Did I miss the exam?
What's that?
Did I miss the physical exam?
We did. We talked about it a lot, head to toe. So his range,
What the actual results were?
his range of motion, he had a little bit of internal rotation deficit, and overall arc was off about maybe 15 degrees or so to the contralateral side. His pain was, as I said, posterior located. He actually had pain with some posterior loading of the joint. He did have some kind of slap findings, so kind of a crank and an O'Brien's test brought him some pain. His rotator cuff strength was pretty good. Did have some pain with some impingement testing, but really nothing too focal there. Anything else you're looking for?
No, that's
Anything
good.
else anybody else is looking for in the exam now that you've seen the MRI and kind of backtracking a bit?
Well, you just want to make sure his scapular mechanics are okay. I think that will play a big role into this. And I think, it sounds like he's got a little bit of GERD, and he looks like he's got some internal impingement findings here too. So I think the question here is, has he fully kind of rehabbed this before we consider thinking about anything more aggressive?
So, Robin, what are you telling this guy about his MRI? What's your interpretation of at least what I gave you here as far as his MRI?
Yeah, from the clips I saw, I mean, he's got an internal impingement component, slap tear, undersurface rotator cuff tear, kind of the standard findings in a pitcher, right? And the question is this a chronic issue or is it more acute? Is that slap tear acute or is it chronic?
What do you think?
Can you show me the images again? Can we go back?
Sure. I think. What do you think? Acute or chronic?
Yeah, it's really hard to say. I thought he had a splint into his biceps, but I don't see it. It sounds acute in the sense that he had something acute happen, right?
So something shifted for this guy. He had some soreness, but obviously there was a moment where really something seemed to get worse. What about the cuff insertion there? Is that worrisome to you?
Yeah, he's got a partial thickness cuff tear. It's an arthrogram, so it often looks worse on the arthrogram than it is, right? So I don't routinely get an arthrogram.
So you don't get arthrograms?
I don't.
How many in the panel get arthrograms in this patient?
Probably would.
All right, so 50-50. How many get an Aber view for this when they're getting an MRI?
I would.
So about 50-50, maybe a little bit more than that. All right, so let's talk you through what we did here with this guy. So he was shut down from baseball for 6 weeks. We sent him for some rehab. One of our therapists upstairs has a focus on this, so I got him plugged in with that. They did focus on the scapular mechanics. They did some cuff range of motion stuff. So Yoni, take us through, kind of the high points as far as how you would approach this guy from a rehab standpoint.
Yeah, so a lot of that is really going to focus on his deficits. And I hate to simplify it, but you guys know that an MRI of any elite level thrower is going to look like a bomb went off in a shoulder, right? And so you really can't treat that. I think it's more important, obviously I'm biased because I can't do anything but treat what I find in my treatment room, right? And so where he's weak, I'm going to strengthen him. And I think one of the faults, speaking from the rehab side, is that we don't approach that. Like these 6 weeks, we need to really become strength coaches. And we need to take the science of loading and strength and conditioning and apply them here and then get position, sports for sure, but position specific in terms of what they need. So that's what I would do. So if you say his cuff isn't weak, then I'm thinking, okay, he's 15 degrees. Is that technically GERD? I think that's really on the line of whether that's problematically GERD. So maybe there's some stretching, but there's actually going to be far more eccentric loading to increase his range, and that's far more important to me than doing the sleeper stretches of the world.
Okay. How much time do you think it will really take to get an idea as to whether or not this approach is going to work for this guy?
I think you're going to know in 6 weeks if he's on the right path. I think by that point, we've gotten his strength where we want it. We know that strength will increase within 2 to 3 weeks. We won't see hypertrophy until 6 weeks. That's that strength and conditioning side. So we should know if we're headed in the right direction. He has probably started throwing in this, like right at this 6 week world.
That was the timing we used for him. Brad, you have a comment or question?
For those of you who are getting the overview, what value does it provide to you and how does it change your treatment protocol? I don't think so.
Who wants to take that one?
I'll take it. I usually see on that one, you can see the undersurface cuff. Really, if it's delamination, you can see it kind of open up there, and you can get a better sense of, in my opinion, how deep the tear is and how much it's impinging. Just gives me more information.
I mean, Robin, you can chime in too, but Robin and I kind of both trained under Jim Bradley, and one of the phenomenons of sort of dynamically being able to see peel back is something that's very hard to see, I think, just on a coronal view. So if you have a slap tear, but it doesn't move at all in the Aber, in an Aber view, then it may not be as troublesome as you think.
All right, so let's move forward in the case. So we spent, the timing worked out where he could do most of his rehab before he departed for college at home. He did see some improvement in symptoms, but he wasn't really throwing. And so we got with his collegiate trainer and put together what we thought would be a reasonable throwing progression when he went off to college. Unfortunately, the symptoms basically came back immediately upon throwing. And so we were encouraged a little bit going there, kind of hesitant, but encouraged, and unfortunately really he struggled quite a bit. So at this point in time, let's say, you start to navigate a throwing progression, he's still having a fair bit of symptoms, cannot progress. What's the next step for you? So Brandon, what do you think you'd use in this guy? Or does he go to surgery at this point?
It depends on how big of an issue timing is. So if you had all the time in the world, then I would definitely start as slow as possible, because the last thing I want to do is operate this guy's shoulder. We know that the results have shown that slap repairs, biceps tenodesis in overhead athletes don't do that great. So for me, if we had all the time in the world, I would definitely try a steroid, because I do think there's some benefit to PRP, but I usually try a steroid because it's cheap for these guys, and I sometimes have a hard time justifying $1,000 for something I don't know if it's going to work much better than a steroid. That being said, if timing was a huge issue and he was very much against an injection and wanted to fix, you could certainly consider surgery, but I tend to slow play these more than maybe most do.
So when you say time is, so how quickly is this guy, if he has a successful result from surgery, when's he throwing again?
So he's not throwing for me until at least 4 to 4.5 months after a slap repair.
Okay.
So, and then he has to go through a throwing progression, which is going to be off the mound by somewhere around 8 to 9 months.
So this guy, it's now early September. Their season really starts beginning of February. So if you operate on him now, you think he'll be back playing?
No.
Okay.
So I think we have a lot of time. This is my point for this guy. So for him, I would start very slow. So I would start with the steroid.
Yeah, because that's what they want to know. When am I going to be able to play baseball again? And typically 4 months is obviously going to be a pretty quick timeline for that. So steroid, are you going to do that in the joint, in the bursa? Where are you going to put it?
I would do it intra-articular. That's just how I usually do the slap ones. I usually and I don't use an ultrasound to do it. I probably should, but I don't. I just feel for it and put it in the joint. And I usually keep them around for like 5 minutes or so afterwards, and just go see another patient. I'll come back and just re-examine them real quick,
Okay.
and to see if they get any pain relief at all. They get no pain relief at all. Even from the initial numbing medicine, I don't love that when that happens. Either maybe I missed, or I don't think they're going to do very well from the shot. If they get some pain relief, at least for some period of time after that, I'm much more encouraged.
So poll the panel. How many people are going to offer or recommend an injection at this point? Hands up if you're yes on an injection.
I think
Brandon's the only guy.
Well, I think I would talk to them about it. I wouldn't do a steroid. I don't do intra-articular steroid injection. So
Ever for any patient?
not really.
Okay.
No. I mean, unless somebody has arthritis and we know that I have arthritis, but otherwise not doing a steroid. So are we going to do something biological? Are we going to scope his shoulder? I mean, he's at that point. He's failed his initial treatment, right? So have a long talk with him. I mean, he's going to miss his season. So we have a little time with him. So we could offer a PRP or adipose stem cell
So when you say
injection.
biological, that's PRP in your practice right now? Or what are you
PRP or
using?
adipose stem cell injection, or,
Okay.
that's an option, certainly. Is he going to do well with that? Probably not.
Yeah, what's your success rate with that in this circumstance?
For an acute injury, probably not as good, but for the chronic ones, it works well.
Yeah. Yoni, when you're seeing these patients, if we do an injection, do you notice an improvement? Do you think it has benefit? Have you seen it have benefit?
I have seen it have benefit, and I think an important piece would be, it's interesting that once he gets back to throwing, he has his pain. Now, is that physiologic, or is this a mechanics thing, right? And so how is he being assessed in terms of his throwing. So he saw PT, he saw his AT in school. What's the pitching coach doing, right? Like, is he speaking the same language? What kind of tech is he using to measure? I would really want to know those things and see if we can tweak that, because like you said, now we have time.
Yeah. All right, well, so for the sake of time, we're going to fast forward. So we actually did try an injection. He did have a diagnostic response. It didn't give him much lasting improvement. We felt that really at this point this season, if he needed surgery, was not going to be viable. But eventually, I think in the ballpark.
What'd you inject him with?
So any of the panelists, have you been using in-office nanoscope, take a look, dynamic? Look at-
Anybody using nanoscope?
No.
Anybody in the
I think it's a
audience
great
use that
idea,
yet?
though, Anand. I mean, it's a great idea. I mean, this is a perfect one to scope, the nanoscope.
So, Anand, I'll ask you the question back. Is that something you think would be a benefit here? What information you could glean from that that's going to guide you one way or the other?
Picture is such a dynamic problem, so I can see you've really got internal rotation, how thick the cup hair really is, how quality the cup hair is, and then if the slap is really degenerative, or like a nice pristine type 2.
Yeah.
But are you going to fix his
So
cup based
representing
on what you've
Naples,
seen?
Florida, Dr. Parsons is going to give us the perspective. Have you tried it in the office?
That's hard to see. You can see maybe it's not hitting the undersurface of the cup. Dynamically,
Yeah.
it's not so easy to do.
That's
Are you
true,
doing
too.
water or air? You do remove the ceiling. Better air. Yeah, seriously. Okay, air.
All right, so let's move along.
Steve, can I just ask another quick question
Yeah,
of the
yeah,
panel? So we've injected steroid in him, okay? How soon after your steroid injection are you all comfortable operating? So
Oh,
in this case,
operating on him?
so you did a steroid injection,
Yeah.
didn't work. Are you operating within a couple weeks or a month or?
So
6
no, with
weeks?
steroid at our place, and we published on this, it's a 3-month, kind of essentially mandatory timeline. PRP, I'm not sure if we're quite as rigid. I'm typically not quite as rigid, but there's still some risk there too, just from the puncture into the joint. So, all right, well, we have some other cases, so I don't want to kind of linger too much on this. But basically, this is what he looked like once we scoped him. So he did end up coming to surgery. He had a type 2 slap tear with some extension and some kind of abrasion kind of posterior superiorly. You can see here, this is, well, in a second, you can see what his cuff looks like. There we go. So that's what his cuff looked like in the joint. Initially, it looks pretty bad. And I'll show you what it looks like when we debrided it. I think there's a video here as well, so you can kind of see.
That's why I mean the nanoscope, it gives you at least some, you can educate the guy versus, yeah, I'm gonna go look and see.
Yeah, honestly, I thought his MRI showed it pretty well. I was personally a little bit pessimistic that he would get better without a scope based on how that MRI. I thought his cuff looked really worrisome, and I feel like that's probably what changed between kind of sore shoulder and what he had. But you can see dynamically and intraoperatively kind of what's happening with this guy's shoulder. He's kind of beating up his cuff, so he just needs more space there. So from a treatment standpoint, and why don't we go with Albert? Slap repair, slap debridement, rotator cuff repair, rotator cuff debridement, anything additional?
I think the slap you repair, that looks like it's peeling back from your probe. So I would just do 2 in the back, or however you would take a very little bite of the labrum, or no bite of the capsule, but pretty just around the labrum, and then debride the cuff.
Okay. Is it just to breathe the cuff?
Yeah, I wouldn't.
Anybody do something different
If
than that?
if you want him throwing, I don't think it would be a great idea to fix that.
All right.
Rob, quick question. Scholarship, no scholarship, position change.
Neither of the position change wasn't discussed.
Playing shortstop and pitching or?
He's a pitcher. He was recruited as a pitcher. I don't know if he's a scholarship or not. Robin, anything you would do differently?
No.
No? Anybody else? Nobody's fixing his cuff? All right. So, shoot, the animation didn't work, but you can see I fixed his slap on the bottom left, and I debrided. You can kind of see it pretty well on the kind of the top right sequence there. Cleaned it up. It went a fair bit deep. This was more of a kind of moderate grade, probably about 5-6 millimeters into the tendon. So tried to kind of smooth it out as best as I could. And then I actually did inject a little biologic into it as well before we finished up, because what the hell, I was a little worried about his cuff. All right. Any comments, criticisms, anything else you'd add? All right. Any other comments on that case? So just to give you, so that was about 3 or 4 years ago. He came and we play William & Mary every year, and he came and pitched the following season against us. He was able to get back. By and large, did okay. About as good as these guys do. Was able to get back to play. All right. Any other comments on that case? Let's move on to something different. All right, another case. It's actually one of our players from this past season. Hopefully you all kind of watched some of the late parts of the season. We had kind of a nice little run. So this guy's a 22-year-old, so he's a fourth year. He throws hard. He's mostly a reliever. He's kind of one of those guys on and off shoulder discomfort, kind of just guts it out. I think he had a subacromial space injection that was done by one of my partners, who's really the guy who primarily takes care of our baseball team the season prior. He pitched well all season. He was kind of one of our dominant kind of, relief pitchers. He's a second-team All-American, apparently a top reliever on the team. So anyways, began to have some worsening posterior inferior shoulder pain after a longer outing, kind of like mid-season, but it really spiraled towards the end of the season. Pain again was in the late cocking position, started to lose his location, and by the end of the year, he really just could not effectively pitch any longer. Examination, actually fairly benign in the office, full pain-free range of motion, normal strength, mild pain with forceful apprehension maneuvers, mild pain with the resisted throwers test. Range of motion was actually fairly symmetric for this guy. They had been kind of working on him or working with him very closely for the kind of the preceding 2 years or so to try to keep him kind of well managed. Not seeing much progress with rest and rehab, has not, and so at this point we're going to the postseason and he just really can't pitch at this point in time. So we got a little bit more imaging. We had not had any prior MRIs in this guy. So I'll show you the MRI here. First of all, this is so we did an arthrogram, whether you guys like it or not. And the reason I'm showing that is you can see the contrast may be leaking a little bit there. So it's something that kind of in hindsight, the radiologist pointed out to us. All right, so here's his axial cuts and hopefully this will play. Little sneaky radiology arrow there for you guys. Couldn't get rid of it. All right, and then here is a coronal view of this shoulder from back to front. Another arrow, it'll help. All right, Kyle, what do you think? What's your interpretation of that MRI? Admittedly, I thought it was one that was a little hard to interpret.
Yeah, I can't really tell what's extravasation there from the arthrogram, so it is difficult. I couldn't tell if there was a small posterior tear in the posterior labrum there. I wasn't sure. I thought I saw a signal coming through there.
Okay. Anybody else have any thoughts?
Where's his pain?
So his pain's really posterior.
Yeah.
But his exam is really, really benign. And really the only thing we could kind of find was some pain in kind of far abduction external rotation.
Do you think that
See, it
is
looks-
that
lat? I was
Steve,
just looking at
it
his
looks
lat.
like Terry's major.
I was gonna ask, yeah, Terry's
Intramuscular
lat, yeah.
Terry's major.
Yeah.
It looks like a,
Terry's are a lot
Um,
right there, yeah.
So there was extravasation. So what we're seeing there, and I'll show you some select cuts. So there's extravasation of contrast, right? And for those of us who get MRI arthrograms, sometimes that's user error. They inject and they miss. But in this case, the radiologist felt that likely was not the case. And then if you look here, you can see this little band of tissue that was kind of interposed in his joint. We weren't quite sure what to do with that. And then inferiorly, kind of more anteriorly in the joint, there was kind of almost what looked to be a capsular disruption there. So we spent a fair bit of time looking at this and thinking about it. Actually had a couple of folks who take care of a lot of overhead athletes take a look at the MRI. But we eventually settled on a diagnosis of essentially an anterior capsular tear.
it looks
Yoni?
like almost anterior inferior with that
Yeah.
extravasation through them.
So Yoni, have you ever taken care of this type of injury rehab-wise?
Yeah, I have, and I've seen them try to be repaired.
Yeah.
Didn't go.
So I like it when the non-op guys telling us to get right to the surgery, which is what this guy ended up having. Any other comments? So let's say you're going into this, Samir, so let's say you're going into this with a diagnosis of some sort of capsular injury. What do you think your approach is going to be? What's the Curlin Job approach to this as far as treating it?
I think the biggest issue you got to talk to the athlete about is that this could be the beginning of the end for him, because this is the white flag being raised by the shoulder saying, look, no mas for me here. So no matter what we do, whether we rehab him or we fix him and rehab him, he may never be the same ever again. And I think he needs to know that really clearly, that, as my partner Jeff Lavallo says, we may be rearranging the decks on the chair of the Titanic. So.
All right, so you're not going to tell us how you're going to fix it, but you're tell him
I
how
think you
it's
said
not fixable.
going in, which, I tell them, hey, we can fix it. And you can usually get to these arthroscopically unless they're way at the bottom, and I tell them that we may have to open it to do it. But I'll try in this case to try to do as best I can arthroscopically, maybe a transsubscap portal there too to get the capsule repaired.
So you're going to try to fix this arthroscopically? Yeah. Anybody going to do this open? All right. So here's what it looked like with the scope. There was this kind of, this was the thing we were seeing interposed there, so side by side. And then here's his capsular split going down. So really basically tracked along the labrum kind of at the 2 o'clock, 3 o'clock, 4 o'clock position, and then it basically became a capsular split that went all the way down to the humeral attachment. So we got a video of the case that hopefully will play. Maybe not. I wonder if I hit the button again. There we go. All right, so this is this guy's shoulder. Kind of an interesting injury. It's not one, this mechanism or this particular pathology is not something that I had seen very much before. First of all, examination under anesthesia. He had some laxity anteriorly, but not overt instability. He was probably like a kind of a loosish 1+, maybe just to the edge and over. And you can see there's that capsular tissue right there. And then in a second, you'll see kind of, we start moving it around, try to get a feel for where this goes. Anybody treated something like this before? Have you guys seen this in a picture?
We had 2 actually over the past couple of years.
Have you?
The major league
In
level.
Major League guys?
Yeah, and they
And-
were fixed and came back to play.
Came back to play?
Anterior, posterior.
Anterior, just like this.
So it looked just like this?
Yeah.
What do you think the
Fixed
mechanism of this
arthroscopically.
is?
I
Do you
think
it's attritional, or do you think it's traumatic, or?
a kind of a combination of both. I think it's attritional and then a traumatic event typically.
Yeah.
Sudden onset.
So anyways, it's about a 5-minute video, so I'll let it play while we talk about this. But basically, we tried to figure out how this aligned, and in the end, you'll see we ended up starting by repairing it back to the labrum up top, and then we kind of went side to side. And if I had the computer up here, I could kind of speed up the video, but I think if I hit the button... we're
Steve, so it's
basically-
more of a split. It's not a haggle. It's not really pulled out. It looks like this
No,
humeral
so
attachment.
the
yeah.
humeral attachment
Yeah.
was still intact.
Yeah, which is nice actually.
Once
Then
we
you can-
had this fixed, so you can see how it aligns there. Once we had this fixed, and here I'll show you some stills. So basically, we repaired it side to side here, and up to the labrum with an anchor, and then we kind of overwrapped that on the left. That's we had already repaired it, and then we overwrapped it with an anchor into the glenoid. So there's 2 anchors kind of placed high, and then the rest was a capsular repair. So he is now just over 6 weeks out. He's actually gotten his motion back very well. He's not loose, and thus far appears to be doing very well. The question becomes now, what do we do, and how do we rehab this, and what are the next steps? And I honestly don't know the answer, so maybe you can tell us. It was probably, I mean, we just had it in an arm position here, so I didn't really pay close attention to it, frankly. I mean, he wasn't way out to the side. He was kind of, probably at 25 to 30. But basically, we repaired it. We didn't really try to tension it. And I don't know, maybe we should have.
I don't think so. No, it's a side to side. Did you do it beach chair or lateral?
Beach chair.
Historically, the anterior capsular tear is an older picture, they go on that now first. Picture that anterior capsular tear is therapy. It's not a great condition to have as far as getting back from because they're older, they're back, but hopefully, surprisingly, really.
Yeah, and our 2, they were young actually. Young. They were young. 5, 6 years in.
Yeah,
And both of
any-
these were acute.
So Samir, or maybe Paul or somebody, this is something that Job, I think, wrote a fair bit about as well, right?
And Neil still talks about capsular tears in throwing, I think. I saw one recently, a professional tennis player.
So from a rehab standpoint, Yanni, what do you think we do with this guy?
Well, I think if you go back to that first picture, it's really interesting. Like to me,
Which picture are you talking
the very first, when you first
Oh.
intro the
Okay, got it, yep.
Yeah, because the rest is gibberish to me.
Right there?
No, keep going. When you first introed the case, it's when you just showed a picture of the guy. Now it's a still,
Oh.
but I'm super interested as to what transpires right before and right after that initial still. So if you look at the guy's lead leg,
Yeah.
he's got a good bit of left knee flexion here, his lead, and so if that angle continues to increase as he traverses forward, a
That's the guy.
huge amount of more stress is going to go through his shoulder. So you want that lead leg to really firm up and that angle to actually decrease. And if you look, he's a huge rib flarer at this point. So his ribs are all the way up. So that's why it was interesting to hear you guys talking about, it was interesting to hear you guys talk about lat perhaps being involved because these guys tear their lats like crazy. So now, again, it's a still terrible way to assess pitching motion, but I would love to see where that goes just for what it's worth.
So just, and obviously, he knows we're presenting this case. This is actually this pitcher, so this is him.
Yeah.
That's how he throws. And so you're paying attention to healing, you're paying attention to range of motion and strengthening, but you're also paying attention to the mechanics of throwing.
Yeah, no,
to try to de-emphasize whatever caused this, yes?
Absolutely. And this is, this is later. The first thing we want to do is not screw up what you guys did.
Mm-hmm.
But once you get down the road, this is where a baseball specialist, overhead specialist comes into play. They got to know this stuff. So
Got it.
We do blame you, though.
I know you do. You guys all blame me.
All right. So I'm going to fast forward through case 3. We got about 10 minutes left, and I want to spend a little bit of time talking about something a little bit different. I'll go quickly so you can't really tell what it is in case we want to go back to it. Case 4, though, I thought instead of the Jacob DeGrom, we'll go after the, and I'm not sure if I can even name him. Where's Warner? Who's the softball pitcher you guys had during your run? Women's softball. Brian's not even in the room. All right. Odyssey. So my daughter's the next Odyssey Alexander. So this is a patient that we treated. This is actually her as well. 19-year-old college softball pitcher a couple years ago. She's left dominant. She throws with her left, and this is her left shoulder. She is kind of a long reliever. She doesn't start, and women's softball is a little different as far as how they use them. But basically, I think it's mostly short spells. She's first year, and she was pitching. It was kind of mid-season at this point, and she felt a really, really sharp pop in the front of her shoulder while throwing a pitch 2 days ago, and her trainer brings her in for an evaluation. So, Albert, why don't we start with you? What are your thoughts here? How are you going to examine or work this patient up?
I think so. The softball pitcher mechanics are obviously a lot different than the overhead, and I think these, because of the motion here, usually the anterior, the sort of the biceps region or sort of the biceps complex is a little bit usually more involved in sort of like the slap region. So that's sort of where I'm thinking right now when I hear this story.
Mm-hmm. Any other comments on that? What do you think, Samir?
Yeah, the biomechanical studies all show that, even though we all think that softball pitchers don't have as much stress on their shoulders than baseball do, they really do. They have a lot in the windmill mechanism, especially in the biceps. So, the fact that they don't have pitch counts in softball and they can, pitch them, let them sit for a couple innings and come back and pitch them, just to me seems like stupid. But that's how this happens, But to me, I'm worried about the biceps and in here.
All right.
Also
So-
subscap, I think about too.
Mm-hmm. All right, so we got an MRI on her, just to kind of fast forward to the meat of the case. Here is her shoulder from back to front. I'll go kind of step by step for you guys so you can take each of them in. And then here's some axials. These are essentially in sequence. All right. So no arrows this time. So who wants to take a swing? Brandon, you want to take a swing at this one? What do you think? Did you see much there? And I can go back through it if you want to go.
Yeah, can you do it one more time?
Sure.
I'm not as
You got some
So-
dye outside the shoulder.
not
there,
as
Lauren.
quick as you guys. Yeah.
What's that?
The
They did a
dye.
great job with the radiologist. Got some subcute.
All right, here we go. All right, so that's posterior, moving to anterior on the
Yeah,
coronals.
just a little bit going under a labrum there. Cuff. Okay. Hard to see the biceps on it.
And what about there?
So the biceps starting to subluxate a little bit there immediately. It's a little.
So I think, Robin, you were calling that out. So that's normally what you do see with an arthrogram is the kind of tracks,
Yeah.
essentially. But that's not really extravasation. That's just kind of as they're pulling it out, you get
Yeah.
a little leakage. All right. So diagnosis. Anybody want to hazard a diagnosis? Have you ever seen this before? No?
I'm going to Google it because that's what Luke Austin said we can do, but no, actually, I do think that anterior capsule on the rotator interval looks like it's got really some fraying there, and I'm worried
All right.
that there's a tear
So
there.
you're worried about the anterior capsule.
I think the biceps doesn't look like it's sitting right in the groove either, so it might be like an interval kind of capsular type tear.
So you don't think it's sitting right in the groove, kind of higher up or lower down?
Looks like higher up, to be honest.
So you can see
like
it right
kind of
there and
interval
there.
capsule.
Looks like a superior glenohumeral ligament, like
Yeah.
biceps subluxation, upper subscap.
It's polylesion? All right. So, fast forwarding to the meat of the case. We did try to treat her through the season. We tried to rehab her back. She didn't really, on her exam, didn't see much in the way of a Popeye sign. She eventually was just not able to get back in and pitch, and so we operated on her kind of late spring, right as her season was ending. And here's what we found. So upper left, you can see complete rupture of the long head biceps tendon. And upper right, you can see it was just like hanging out like a gopher in a gopher hole, just sitting there. And so you can see the bottom left, I'm pulling it out, and you're kind of pulling it across. It's basically kind of stuck there. Extra articularly, you can see there was a secondary kind of attachment in the groove, and that's why it was stuck in place versus retracting all the way down. So you can see that far upper right picture, the actual long head biceps tendon is actually pulled out of the groove and kind of dangling off in the wind, and there's this little band of tissue kind of holding it in place. Anybody ever seen this before? Yeah, I had no idea what to expect going in. I thought it was, like you, Albert, I was highly suspicious of a biceps tendon problem. Eh, What's that? I think what she felt was the thing rupturing.
Yeah.
Well, I think part of it was because it was stuck there in the groove. And I don't know. I mean, they talk about it. This has been described in the windmill picture, but there's probably some component of contribution to the biceps tendon. But now it's ruptured, so you can't obviously put it back. So treatment for this, what do you think, Samir? What would you do with this?
At that point, just do a tenodesis.
Okay. Just do a tenodesis. What kind?
Lower down, do a subpec.
Subpec tenodesis. How are you fixing it?
Screw.
Screws. Okay. How big of a screw?
Small as I can get, 4 or 5.
Yeah. All right. Albert, how are you fixing this?
I mean, I like intra-articular tenodesis, but the amount of kind of redness there, I would take this out of the groove and do a subpec, and I would use a little, either I use a little button or I use a tack that's like, kind of 1 point, a very small button with an onlay kind of approach.
Okay. Robin?
Same thing as
Same.
Albert.
Kyle? Anything different?
Yeah, I'm also doing a subpec tenodesis. I don't use any implants, though. I just use a docking technique into a small tunnel.
So docking technique into a tunnel, and how do you secure it?
So this goes back to like years ago with Romeo, and I never changed, but I really like how it works. But I just use a tunnel that's drilled about the size of the tendon, 2 very small drill holes beneath it, and I retro pass a PVS suture, and then I use those just to draw the.
How big of a hole do you end up having to drill?
Usually it's a 5.0 or 5.5 drill.
And the tendon just gets stuffed
And
in there.
I try to get it to be a nice tight fit there. And then the sutures that I whip stitch the tendon are coming out the smaller holes and tied over a bony bridge.
Okay. All right. Brandon?
Button.
Button. All right. Subpec.
Yep.
All right. So we did a subpec tenodesis with a button on her. And that's actually not her pictures, but that's what we used. All right. So we got a couple minutes left. So, Yoni, give us some education on the windmill softball pitcher, how you rehab them if they have trouble, and then more importantly, how you would actually approach this particular patient post-op.
Yeah, I mean, things to note are like landing mechanics are going to be far different. So they're going to be far more comfortable getting into that terminal extension with that lead leg. So that'll be a lot easier. I'm sure it's different, but I think the softball game has a long way to go, like you were talking about before, Doc, in terms of arm care and in terms of periodization. I just spoke to a team out in Alabama. There is no off season. And so kind of educating along that world, but kind of the basics that have bled into this baseball world, which are you better know where your scaps are. You got to hit them in retraction and protraction. I think that's lost on a lot of some of the rehab stuff, and make sure they're loaded appropriately so it's not so different.
All right. And then post-op for this one, you'd work on range of motion. Anything in particular that you think helps? I mean, she's lost her long head biceps tendon. Do you think that has any consequence in either the overhead thrower or the windmill thrower?
What Dr. Andrews says, like God put it there for a reason, right? So I'm sure it does have a place and a purpose. With most things, especially with when you start messing with the long head of the biceps, I really hammer stability, and I love doing that in a closed chain world and without visual inputs. And that's just like a rehab training thing that they got to know where that humerus is in space and train that.
So this operation was done basically in like the early summer, and the plan was to try to get her back to playing some in the fall. She struggled a bit. She did okay. I mean, she did actually very, very well, kind of, the typical stuff we look at, but then the throwing progression was a little bit bouncy. She was able to get back to playing in the spring. That was 2 seasons ago, and she's pitched 2 subsequent seasons. What do you tell this patient? So biceps tenodesis and a thrower, what do you tell them their return to play timeline is if you guys have ever done any? First of all, how many people in the panel have done a biceps tenodesis in an overhead athlete? A couple. Have they gotten back to playing? Yeah. Have they gotten back to playing more or less predictably than a slap repair?
About the same. Oh, no, excuse me, compared to slap repair, better, more predictable.
More predictable?
Yeah.
What about, who else? Albert, did you raise your hand or no?
Yeah, I mean, it's not super frequent, but occasionally you deal with an issue like this where the tendon looks like, looks terrible. And so you have no other option. So
Right.
They weren't pitchers in my case, volleyball, tennis, and position player.
same as well. Yeah, I've not done this in the pitcher.
Robin, what's the major league experience if you know, with tenodesis in throwers?
Very low.
Very minimal,
Yeah,
right?
minimal.
All right. All right, well, we're exactly on time here, so we'll go ahead and close it out. Thank you to all of our panelists.